course, your institute is very large.
And almost we in fact I have not even had time to look at the data, but actually 3,000 and plus cases we have seen, sir. Neurology.
Amazing. Hi, Jimmy.
Hello, hello.
Good
Good
evening.
evening,
Hello, sir.
everyone. Good evening.
Hi, Jimmy.
Hi, hi.
Good
Hello.
evening, Jimmy.
Oh, hi, Sudhir. Keમ
Good
છો?
બસ મજામાં બધા સારું.
બધા all okay. Nice to see you.
Yeah.
Thank you. Most welcome.
Suma is also joined.
Thank you for
Suma, good evening.
joining.
Sir, in fact, sir, Jimmy sir's the
Hi,
hereditary
hi,
neuropathy
hi,
was-
Dr.
Sir, good evening, sir.
Lakshmi.
Sir, I enjoyed your hereditary neuropathy, sir.
Thank you.
It was very good, sir.
No, it was a pleasure to have you. You were also there. It was a pleasure.
I really enjoyed. So the way in which you consolidated what should you know? There are so many things, but you really consolidated very well, sir.
Thank you very much. Thank you.
I
Thank
really
you.
enjoyed it, sir. Thank you.
Thank you so much. Thank you. Hi, hi. Hi, sir. How are you?
I think the participants are over 100. So, do you want to start?
Yeah, we'll start, sir.
In Lakshmi?
Yeah, it'll
Yes,
increase,
sir,
sir.
we can start.
It's rapidly increasing. Let's see. It has become 122, 126.
Manoj, sir,
1
can you
minute
start,
past
sir?
8. 1 minute past 8. If you want to wait for a couple of minutes, that's fine. If you want to start, whatever you.
No, sir, in the meantime, we can do the introduction. In the meantime, the
Introductions
people will
and
join.
those things we can start.
It's
It will
already
take 1 to 3 minutes.
128 people. Yeah.
Manoj, sir, you can start, sir.
Yeah, sure.
Yeah.
Good evening, ladies and gentlemen. Welcome to another interesting webinar, Secrets of Neurology, Clinical Pearls, coupled with recent therapeutic advances, a monthly series for the year 2020-21. And it is being held on the last Friday of every month.
Thank you.
Today, we have a galaxy of experts who have come and given their time to mentor, coach, and bring out the best out of their mentees. I would leave the introduction to the two program directors for this evening. An honor and privilege to introduce Dr. Sudhir Shah, Professor and HOD at prestigious NHL, MMC, and SVPI, MSR Ahmedabad. And Dr. Sudhir Shah is also a director of Neuroscience Sterling Hospital, Ahmedabad, author of 6 books on neurology. And because of his excellent work in the field of academia, support to his patients, and academic work, he has been conferred with prestigious Padam Shri and Dr. B.C. Roy Award. We have another stalwart as a program director, Dr. Lakshmi Narasimhan, Director and Professor, Institute of Neurology at prestigious Madras Medical College, Chennai. Many laurels and accolades to his credit, but I would just keep it short for tonight. Literacy Advisor from AN 2007, A.B. Baker Award, Best Paper Award at AN, Global Elsevier Atlas Award, August 2015. Many contributions at leadership role in the field of neurology. May I invite both of you as a program director, take it on from there, sir.
Very good evening. I'm Bhim Singhal, and my co-person is no less a person than Dr. Nadir Barucha. So it's a great pleasure, really. Thank you very much for inviting me. I think this is the brainchild of Dr. Sudhir Shah, along with Dr. Lakshmi. And I think there can't be a better learning process than to learn from a case. Each patient will teach you something. And if you analyze the case very carefully, both academically, scientifically, you will learn something new. And today's case is going to be a clinical pearl, as Mr. Chadda has said, which will teach us many lessons. And I'm looking forward to listening to this very, with all the attention that I can pay. So I think it's a great pleasure, really, for me. And thank you very much for asking me to initiate this, because I think I found in my life that the best way of learning is on a case. So I think you have an interesting case presentation today. And maybe Dr. Nadir may like to add something to what I have said. Nadir, over to you.
Yeah, thanks, Bhim. Essentially, can you hear me? Yeah, okay. Essentially, I think I'd like to say how much of a privilege it is for the Department of Neurology at Bombay Hospital for having been chosen, selected to make this presentation. And just a few words about the department, if I may be permitted. Not without going into the background of the department and Professor Bhim Singhal and Dr. E.P. Bharucha, but dealing with the current scenario with Dr. Satish Khadilkar heading the department, and a very dynamic team that he has promoted, I should say we have promoted, and a very active learning program, also partly transposed from the JJ, but a very open setting in which we find that people from other medical institutes come to the Bombay Hospital to learn. We've got a very good residence training program, and I think superb supportive facilities. That's the last thing I'll say. Dr. Kushnuma Mansukani, electrophysiology, and Dr. Inda Talwar in neuroimaging. Sudhir, you know these strengths of our department, and I'd just like to again thank Dr. Sudhir Shah and the organizers for having, and Dr. Lakshmi Narayan Sinha for having selected us as the second unit to make this presentation. Thank you very much.
Yeah. Can you stop sharing? Yeah. Hello. Yeah. Very good evening to all of you. It gives me immense pleasure to welcome you all for the second episode of this unique webinar series, which is, as you know, scheduled on the last Friday of every month, 8 p.m. onwards. And as you are aware, we are extremely lucky. I mean, we are absolutely blessed with the august presence of two doyens of neurology with us, that is Professor Dr. B.S. Singhal and Dr. Nadir Bharucha. Thank you very much for your presence, sir, and very kind of you for your wonderful words of blessing. As you know, friends, this webinar is meant primarily for the education of postgraduate students of DM and DNB neurology, but I'm sure it will turn out to be useful for one and all, especially the fresh junior practicing neurologists also. The design of the webinar is unique. Actually, Dr. Lakshmi, my able friend, very wonderful personality, and myself, we have conceptualized and designed this power-packed webinar very meticulously to incorporate clinical pulse, localization, pertinent high-value questions, all related to the case. And as you know, briefly, the flow would be first, there will be case presentation by the third year DM student. Then there will be two moderators who will discuss one by one the localization and high-value questions. And then Dr. Satish would take over and review the whole clinical pulse and the advances, etc. I'm fortunate that all these friends, Dr. Satish, Jimmy, are my colleagues and we studied together. And Professor Nadir Bharucha was one of my teachers. And that with Professor Singhal, I had an opportunity to work and observe him closely for at least 6 months while I was working at Bombay Hospital under him. So these are all my family people, and I'm honored that they are all here and they have consented to be here. there'll be question answer at the end, and Dr. Lakshmi would then summarize and do announcements also. Uh, Also now, I would request Dr. Lakshmi to introduce the moderators and the students, etc. But before I do that, I want to sincerely thank Intas, Mr. Chadda and his team for this logistic support and the wonderful homework that they are doing and the way they are spreading neurology across the country. I think it is commendable. I also want to thank the faculty and also want to thank all the delegates, though because of whom we are here. They have shown continuous interest and feedback. So with that, I think Dr. Lakshmi will give further insights.
Yes. Yes.
I think we have already
yeah.
2 or 3 more webinars in line. Thank you.
It's my great pleasure, sir. It's a real great pleasure to have Professor Deem Singh and Professor Nadir Bharucha to have come and blessed us on this day. And I'm sure that the younger generation are fortunate enough to have them with us today. And because their knowledge, they are all Bhishma Pitas of neurology of the country. And secondly, I take immense pleasure in introducing Dr. Riddhi Patel, a second-year student DM neurology resident at Mumbai Hospital, Mumbai. And I'm jealous of her because she's being taught by Professor Satish Kadilkar and team. The most envious team in the country, with all backups, like Professor Mansukani in neurophysiology. You can't ask for better team in Mumbai Hospital. May I have the next slide, please? And Dr. Rakesh Singh, who is the consultant and interventional stroke neurologist in Mumbai Hospital, Mumbai. His areas of interest in stroke and neuro intervention. Next slide. And Dr. Jimmy Lalkaka is a very, I've always felt like learning modesty from him. And he's a great person who's affiliated to the Saifi Hospital, Mumbai and Parsi General Hospital. You will, during the course of this discussion, you will realize how invaluable and how his knowledge levels are. He's the treasurer of the Parkinson's Disease and the Movement Disorder Society and is a specialist in Parkinson's disease. Welcome you, sir. We are grateful to you. May I have the next slide, please? And Dr. Satish Kadilkar, Professor Satish Kadilkar, I would say that I've always dreamt to be on his footpath. And he's, even in a crisis, I have seen him so level-headed, cool, and he knows how to, most important thing in life is to handle people who I have always felt, I've seen him in close quarters for so many years in Indian Academy of Neurology. He has been instrumental for keeping a best atmosphere in the Indian Academy of Neurology. And sir is the Dean and Medical Faculty of Bombay Hospital, Professor and Head of the Department of Bombay Hospital Institute of Medical Sciences, ex-Professor and Head of Neurology in the Grant Medical College and Sir JJ Group of Hospitals, Mumbai. He's a consultant neurology in Bombay Hospital Institute of Medical Sciences in Mumbai, and is an editor-in-chief and analyst of Indian Academy for 5 years. He's a convener of the neuromuscular subsection in IAN. He's the president of the Indian Academy of Neurology, Nerve Muscle Society of India in 2018-19, Maharashtra Association of Neurology, and Bombay Neurological Association. He's a treasurer Asian Oceanian Myology Center, trustee and secretary of the Muscular Dystrophy Society of Mumbai, fellow of Royal College of Physicians, London, National Academy of Medical Sciences, Indian Academy of Neurology, and Indian College of Physicians. 6 books, 43 book chapters, over 150 publications in national and international peer-reviewed journals. Teacher and examiner of DM Neurology, Best Teacher Award in GMC and AGH. Most of all, anybody would like to emulate him in life. I really ask the youngsters to take a leave out of his knowledge, and I pray God that he should give him long life and healthy life. Over to Dr. Satish Kadilkar for further process. Thank you.
Thank you. Thank you very much, Lakshmi. I think the plan as has been described is first Dr. Riddhi will present and Dr. Rakesh Singh will sort of take the discussion along. In between, you will ask her questions to elucidate some of the phenomena that are happening in the patient, and then we go on that way. So, do we invite questions as and when Dr. Lakshmi and Dr. Sudhir, or how do we do that?
We'll have it at the end. At the end.
Let the case get along,
Yeah.
let's get a grip of the situation, and then we can take questions. Yeah. So, Riddhi, do you want to share your screen and start the presentation? And Rakesh, could you please take over? Thank
Yes,
you. Thank you both.
so good evening to all, and truly said, कि I am very much thankful to all my great teachers. So today I am presenting the case of a curious case of lower limb weakness. So this is the 18 years male. He is a college student, no comorbidities, and presented with the chief complaint of gradually progressive walking difficulty for last 2 years. So patient was relatively well before 2 years. Then he noticed difficulty in climbing upstairs that was gradually progressive and need support for the railing for last 6 months, and difficulty in getting up from the squatting position for last 6 months, and need support from the getting up from the chair for last 3 months. So some proximal thing is going on, and afterwards he noticed the marked weakness of the right foot with difficulty in holding the chappal, though it was bilateral, but hello, yes sir.
Ma'am, can you go with the full screen?
It's full screen only.
But we are not able to see the full screen.
So I will share it again.
Yeah, please. Because your slides are not moving. Can you go? Yeah.
Now we can see.
Yes.
Yeah.
Now it's okay. Yes.
Perfect.
Thank you.
Yeah. So 2 years history of climbing upstairs difficulty, and afterwards squatting up position, and difficulty in getting up from the chair for last 3 months. And he noticed the marked weakness of the right foot that was in the direct questioning, but he was having the bilateral foot weakness and difficulty in holding the chappals. Walking became difficult and used to drag the right more than the left foot for last 4 months. No worsening in the dark. Could not balance when obstacle is there. So history of falls thrice in last 2 months. On direct questioning, the relatives told that thinning of distal lower limb muscle was there, more on the right side than the left side, and the buckling of the knee in between while walking, more on the right side. So for the negative history, no any complaint in the upper limbs, no complaint suggestive of bowel bladder or the bulbar weakness, no paresthesias or the sensory loss, no history of fluctuations in the weakness, diplopia, ptosis or the visual complaint, no complaint of the facial weakness, hearing loss or the tremors, no fasciculations, no complaint of skin rash, joint pain or the weight loss. No history of any addiction or the drug intake, no change in the bowel bladder habits, sleep and appetite was normal, born of consanguineous marriage, third degree relative, and no significant family history or the past history. To summarize the case, it's a gradual progressive chronic. Hello, yes.
Yeah, go ahead. We can listen.
Yes, sir. So it's a chronic, gradually progressive, asymmetrical, right more than left, pure motor, lower limb weakness with wasting, without bowel bladder or the bulbar weakness in young male patient. So,
Yeah. Yeah. So, what do you think about the localization?
so it started with the proximal weakness, as he was having the climbing upstairs difficulty and all, and maybe there is asymmetry or symmetry. I would like to confirm on examination, but the proximal with maybe symmetry or asymmetry and without any sensory or the bowel bladder, and the without any fluctuations and no fasciculations, I would like to keep the first possibility of the muscle involvement, and as the second possibility is nerve involvement, because there is asymmetry is also there, and maybe the pure motor involvement and the vesting is there in the lower limb muscles. But I would like to confirm my findings on the examination, if there are any sensory finding or sensory findings are there or not.
Absolutely. Because this is a case of pure motor paraparesis, proximal plus distal, with some asymmetry and vesting. So obviously we'll be considering nerve versus muscle involvement. Now in nerve, what all diseases you can think of? We can go to next slide.
Yes, sir. So in the nerve, proximal and the distal involvement is there, with some vesting is also there. So proximal plus distal. So I would like to keep the possibility of non-length dependent neuropathy, maybe the CIDP or the inherited neuropathy, or the SMS as the young onset, and the asymmetry is there. So anterior onset can be the possibility.
You know,
muscle?
Riddhi, when you say nerve, you actually mean neurogenic, no?
Yes, sir, neurogenic.
You are including everything, anterior horn cell, roots, nerves, everything. No? When you say
Yes,
muscle versus nerve is everything neurogenic, because your diagnosis is one in anterior horn cell, one is the nerve. Yeah.
Yes, sir.
Okay.
Any pointer you will like to tell LGMD versus endomyopathy?
So it's a relatively slow 2 years history, with maybe the differential weakness is there on history. So and some vesting is also there, and proximal as well as the distal involvement. So I would like to keep the possibilities of LGMD first over the inflammatory, because the pain is not there and the upper limb involvement, neck muscles, bulbar weakness is not there. So more likely it's limb girdle muscular dystrophy, sir.
How common is the pain in inflammatory myopathies?
Almost 50% patients used to come with the pain.
It's not a must for every inflammatory myopathy to have severe pains. They have mild ache here, but by and large, they will not have large pain or cramps per se.
Yes.
Yeah. So, what things we like to examine on examination to confirm or to make a diagnosis out of these 5 things what we are thinking?
Yes, sir. So I would like to see for the any sensory findings. So maybe the inherited neuropathy have the sensory findings more than the sensory complaints. Then any vesting, any pattern of muscle involvement, then any areflexia, the reflexes I would like to see, and any upper limb involvement or the fasciculations.
Absolutely. Like, you would like to confirm whether it is pure motor or not, one thing, whether upper limb is involved or not, and any sensory clinically involved or not. Because most of inherited neuropathies may have mild sensory symptoms, and they may come only on EMG and CT. So we go ahead with the examination.
I just want to remind Riddhi that don't forget that this is he's born of some kind of consanguinity.
Yes, sir.
Yeah, it may or may not have a bearing, but keep it in mind. Yeah.
So on examination, he was vitally stable, conscious, alert oriented, and pace chaos was present, that was bilateral, right side more than the left side, no skeletal deformity or the skin lesions. On the cranial nerve examination, it was normal, pupils bilateral equal, reacting to light, no ptosis or the facial weakness or any ophthalmoplegia. So here we can see the high arch foot, and here we can see there is a atrophy of the medial part of the calf muscles. And upper limb and the neck muscles power was 5/5. On the hip, actually on the muscle power examination, no any particular pattern following the common limb girdle muscular dystrophies, but here the hip extensors, hip abductors, knee flexors, and the ankle dorsiflexors were relatively more weaker than the other muscles. It was not following any root pattern. So tone was decreased in the both lower limbs. EDB was vested bilaterally. Sensory examination, touch, pain, temperature, vibration was normal. Deep tender reflexes were deep tender reflexes, biceps jerk, supinator jerk, and the triceps jerk was +1, that was coming with the Jędrusik maneuver, and the knee jerk and the ankle jerk was absent bilaterally. Cerebellar examination was normal. Plantar were bilaterally flexures. So to summarize the case, the young male with the chronic gradually progressive asymmetrical right more than left pure motor lower limb weakness without Powell bladder or the bulbar weakness with areflexia in the lower limbs.
So after examination, what all new things we found or what we confirmed?
Yes. So the vesting of distal EDB muscles were there, calf muscle was there, and no any particular pattern of limb girdle muscular dystrophies that are commonly known was there, and areflexia, sensory findings were normal, no fasciculations and no tremors, and upper limb were normal, and the bowel bulbar weakness was not there, sir.
Right. We confirmed that only lower limb is involved. It is pure motor, and
Yes.
there are some signs of nerve involvement.
Yes, sir.
So shall we discuss one by one what are the differentials we thought after the history? The first is
Yes.
limb girdle muscular dystrophy. Like all of us know that it can present in the middle age group, like in this patient, or a younger age group, pure motor thing. Most of the limb girdle muscular dystrophies will have some sort of upper limb involvement also. This case we have a distal involvement. So which limb girdle muscular dystrophy is present with distal involvement?
So, sir, it's GNE myopathy, dysferlinopathy, anoptominopathy, and other myopathies which are not seen in the India are the Wallender myopathy, Wood myopathy, and Jaspopathy.
Right. So from our country point of view, two things we should remember as far as distal LGMD is concerned. When distally, it is one of the most common limb girdle muscular dystrophy, which will present as a gastrocnemius weakness. And the classical sign described quadriceps is diamond sign.
Yes.
As far as GNE is concerned, they have more of a tibialis anterior weakness, and quadriceps will be normal.
Rakesh, do you want to take a question? Somebody is asked, what is a differential weakness? So you want to explain that a little bit here?
Yeah. Now, in the group of LGMD, I cannot see questions. Chats, it is there, sir?
No, in Q&A, there's a question, what is differential weakness?
Yeah, Riddhi, you want to answer?
Yes, I will answer, sir.
Yeah.
Hello.
So dysferlinopathy and the anoptominopathy most likely involve the posterior compartment of the leg muscles, and the sarcoglycanopathy, like that used to involve the adductors and the hip flexors muscle, and the that GNE myopathy used to involve the anterior compartment of the leg muscle. So this is known as the differential weakness, as we seen in the DMD also. The hip flexors, abductors, and the knee flexors are commonly involved. So the pattern of involvement is like differential involvement in the muscle, the commonly known myopathies.
Absolutely. Like a pattern of involvement in a particular case gives us some clue which limb girdle muscular dystrophy it may be. Like in Disperlin, they will have calf atrophy, but the quadriceps will have some prominent bumpy appearance, which is called Demen's. So that gives us a clue. Same thing is sarcoglycanopathy. It was described by Dr. Khadilkar only, the hip, classical hip adductor weakness. Hip abductors will be normal and adductors will be very weak. So it points that if patient has such a differential weakness, sarcoglycan should take off if we have some additional features like calf hypertrophy and all. But now, as we are seeing more and more cases, we have found that similar adductor weakness can be there in Kalpen also. So if we get a set pattern of weakness, it can point towards some genetic disorder so that we can pinpoint our investigation. That's called pattern of weakness. Now, contrary to this, in spinomuscular atrophies, we will not have these patterns which are there with the muscle. Sir, you want to add something?
No, I just wanted to take another question that Dr. Ilavarsi has asked. Kalpen can also cause a foot drop. Has pointed out actually that Kalpen can cause a foot drop. I mean, it certainly does cause a foot drop, but the foot drop in Kalpenopathies is not as prominent or as consistent as you will see in the GNE myopathy. There's another difference between the two. GNE, there's hardly ever the TA contracture, but a lot of Kalpens will have a TA contracture. Just like Duchenne, they will walk on the toes. So it's not only a foot drop, it's also a TA contracture. So I think that's the thing on Kalpen. Otherwise, differential is points you to inherited, like Dr. Rakesh Singh said. Yeah. Actually, I'm seeing the case almost with you now, so it's new to me as well. Yeah. Okay.
So, to summarize for students, especially for LGMDs, we should know for exam purpose, GNE, Kalpen, and sarcoglycans. They are more commoner in our country. And as we have discussed, for every LGMD, we should know 1 or 2 points which are the pointers for that disease. Sir, want to add something for LGMD purpose?
No, not really. I am just a little struck by the asymmetry. And maybe if one comment I can make on that generally we believe that myopathies are symmetrical. We teach the undergraduates that they're symmetrical. We sort of harp on the fact that they're asymmetrical, they're symmetrical. But a reasonable proportion of limb girdle dystrophies or muscle disease in general can be asymmetric. And the asymmetry is more marked in cases of foot drop. Like I have seen any number of GNE myopathies where one foot drop is more than the other. I've seen some anactominopathies where one is more than the other. So it's important to recognize that whatever features we discuss to try and differentiate between muscle and anterior horn cell and nerve are not absolute in themselves. They are relative. So here somebody's asked a question, since there is an asymmetry, why are we still considering muscle disease? You will still consider, but with reservations. You can't exclude. And the same goes for the anterior horn cell. A big SMA will be symmetrical. So these are relative points. Yeah.
So we go to our next differential, inflammatory myopathy. As we have discussed, there is no fluctuation per se. It is purely remaining in the lower limb with distal involvement. So it's lower on card. So we go to our next differential, sensory motor inherited myopathy. Did you want to discuss what are the points for and against for it?
So, 2 years history of gradual progression with a consanguineous marriage, vesting, maybe the champagne bottle, it's not that much of clear, but the pes cavus and so sir, could be the possibility of inherited neuropathy, but points against are the no any sensory involvement or the no any upper limb involvement and the no any previous history of any milestone delay.
Yes. Now there is pace cavus which is there, which was one of the pointer, but marked asymmetricity which we are seeing is going bit against the inherited neuropathy. Now most of these will have some sort of sensory involvement. So clinically we have not found any sensory involvement per se, but EMG NCV may pick up some sensory involvement. So we'll be waiting for that report to be there. Asymmetricity is going bit against, but still they can fluctuate sometimes, and a combination of inherited hereditary sensory motor neuropathy with some exacerbation will be there. So that possibility we have kept in mind because the history is short and there is pace cavus with distal atrophy. Next differential.
I think
to add something.
We can later on ask Dr. Lalkaka about a little more about the pace cavus because he's seen the patient more than once. I mean, there's a difference between bony pace cavus and muscular pace cavus. Anything that makes the distal muscles weak can sort of look like that. But then when such a patient stands, the foot will become flat. So maybe he can tell us more later. Yeah.
We come to next differential, SMA. What do you think, Lydia, about SMA possibility, pros and cons?
Sir, no any areflexia, no any fasciculations, or over the period of 2 years of the history, no any upper limb involvement, and no bulbar weakness. So maybe it could be involved in the later on, but this is the very least possibility, but the late on the lower downside.
By and large, for SMA predictors are fasciculation. If you have any fasciculation, if you have any tremor, if you have any sensory neuron hearing loss, or early bulbar involvement. Whenever we see a limb girdle syndrome with early bulbar involvement, we should think of SMA. Also, in this case, there is marked asymmetricity, which is bit again. It's less common to have a asymmetric SMA. So obviously, it's lower on the chord, but still will be considered because the wasting seen in the lower limb. Sir, want to add something?
No, Rakesh, there is a question. Should MMN be considered? Will you consider MMN? That's the question here.
Sir, it's a MMN usually are at the upper limb onset, and young onset is there, but the mainly are the upper limb onset, and the multifocal nerve involvement is there. Like they used to present with usually with the finger drops or the wrist drop.
That's right. If you remember Varun Parekh, you remember MMN. It's a wrist drop. It's a young male. It's upper limb. When it becomes more and more, then it can go everywhere. But I think the basic thought that is raised in the question is correct. A pure motor disease which is asymmetrical, MMN will go through your mind. But a lot of them will have a wrist drop and then they'll go.
Yes. MMA is like a pure motor mononeuritis multiplex. Am I correct, sir?
Absolutely. Then somebody is asked, Dr. Pravar Pasi is asked, is pace cavus common in myopathies? No, it is not common in myopathies, but mitochondriopathies are tricky. I mean, they can have nerve, muscle, everything. And Dr. Ilavarasi again has pointed out that pace cavus will probably mean that it is longer than 2 years, which I think is perfectly correct.
Okay. That is one of the reasons we kept the differential of inherited neuropathies.
Correct.
May I just add here about the pace cavus?
Yes, yes.
I mean, it was a high arched foot, but it wasn't really that very typical bony, pace cavus, skeletal pace cavus. It was probably more related to the distal weakness rather than a very typical skeletal pace cavus.
Lovely. That's very good to know. So you wouldn't go too much for a skeletal deformity.
No.
Yeah. Right.
So then we come to our next differentiation, the motor variant of CIP.
Yes, sir. Acquired neuropathy.
Point against or why there is any doubt about the diagnosis? Yeah.
Yes, sir. So it's a like 2 years history of progression with the proximal plus distal asymmetric involvement with areflexia. So without any sensory finding. So I would like to give the possibility of motor variant of CIDP high on the card. But the point against are the no any upper limb involvement, facial weakness or the bulbar weakness, but it could be the acquired neuropathy restricted to the focal CIDP, like restricted to the lower limb only.
Yes. For the exam purpose, yes. By CIDP also should be symmetrical. Here we have a bit asymmetricity, which is maybe a point bit against. Second, 2-year history, initial proximal, then distal, and marked vesting. These are some of the odd features for a classical demyelinating CIDP. Sir, want to add something?
Absolutely. I was just going to say that the pure motor CIDP is very uncommon. So, I mean, it's okay to consider it, but I mean, we know that common diseases are common. So if you want to consider a motor variant of CIDP, immediately you will also consider that, oh, this is a very uncommon disease. So it's good to know that it exists. Some people don't even believe that it exists. So okay, it's there, but it's lower down. Yeah.
So
unless your EMG shows something more, like Dr. Rakesh Singh said, yes.
So frankly, we clinically we thought of CID first, or some inherited neuropathy and some exacerbation with the demyelinating component. That's what in that thought process we'll plan to investigate. So what most important few investigations you will plan, really?
Yes, sir. So, sir, CPK total and ESR and CRP to rule out the to see for any inflammation, and afterwards I would like to consider the EMG NCS first. So to see for the demyelination or the axonal involvement, and we can differentiate between the nerve or the muscle involvement also, sir, and
so,
sensory finding also.
So we give two possibilities. Say the CPK is normal. So what all differentials you will think? How will it will rule out these things?
So after that the some LGMDs can present with the very mild CPK elevation. So it will be on the very lower on the card, but the neuropathy like inherited neuropathy and the acquired neuropathy would be the possibility, sir.
Absolutely. If CPK comes high, it will give us some clue. If CPK comes normal, then we'll go to next investigation. I want to add something?
How high will be high enough for you? Suppose it's 250.
Yes. No.
So what will you consider 250?
So 250. Sir, 250 is actually if the muscle dystrophy is very late, then could have the very low level, and the SMS can have the borderline level also.
Our patient is not very late; he's still walking.
Sorry, sir.
Our patient is not very late in his disease; he's walking about. So 250 for him, how does it help you?
So I would have thought of the possibility of anoctominopathy, dysferrinopathy, as little bit of posterior involvement is more than the other muscles. So that have the very high level of the CPK. So yes, I could rule out that possibility.
Answer really is that if your CK is above 1,000, then you will lean towards a myopathy. If it is under 1,000, then you don't know, because even aggressive ALS can have a very high CK. So slightly elevated CK doesn't tell you anything. It may still be neurogenic, it may still be myopathy. But say 1,000, like you said, 1,000, 4,000, 5,000, then you strongly think of a myopathy. Yeah. So everything has to be put in the perspective. Yeah.
We go for investigations one by one?
Yeah.
Yes, sir. So
will Dr. Lakshmi or Dr. Sudhir want to say anything at this stage, or we go ahead with the tests? I think we go ahead with the tests. Yeah.
So CPK total was 295. And EMG NCS was done. So sensory nerve conduction was totally normal. Motor nerve conduction showed the right peroneal. EDB was amplitude was low for his age, and the right tibial gastrocnemius and the right tibial gastrocnemius was amplitude was low. FA were normal. So needle EMG of the right quadriceps showed the large MUPs, and here the lower down the right iliacus had showed the short MUPs. The right vastus medialis had showed the large MUPs with a little bit of short MUPs also, and the flexor carpi radialis also showed the large MUPs and the short MUPs also. So this is the final report of the needle EMG. The right tibialis anterior was showing the chronic partial denervation, right gastrocnemius showing the active denervation, and the proximal muscles, right iliacus, was showing the active muscle disease, and the gluteus medius also. So proximal, it was the muscle disease, and the in few of muscles, right vastus medialis and the right vastus medialis, it was showing the active plus chronic partial denervation, and the left gastrocnemius was showing the active denervation. So it could not help us a lot, kids.
Was supporting our diagnosis, but not a very classical EMG finding which we like to get.
We have Dr. Mansukani with us. Could we request Dr. Mansukani to tell us more about this?
Yeah, so what was very, very unusual was that the right leg was overall much weaker, but with a very weak iliacus and a gastroc. Can you show the iliacus one better?
Yes, ma'am. Actually, it's just lower down, ma'am. So
if you see the iliacus, barely lift his leg off the hip, I mean from the heel off the bed. But we saw lots of these small units. In fact, the iliacus looked very classically what would you call myopathic. So did the right gluteus medius. These two muscles definitely showed a lot of small units with a fairly good interference. The gluteus was not good, but iliacus was very good interference. Whereas if you look at the other muscles, all the other muscles, quadriceps, tibialis anterior, gastrocnemius, they all showed large units. There were some thin spiky units even in the quadriceps. So what impression we got was that is this a kind of very asymmetric muscle disease which also shows neurogenic potentials like we tend to see with GNE myopathies. Only thing is the quadriceps was not spared. In these patients, sometimes in the upper limbs, you tend to get small units, even if they are not weak or affected. And that is why we needle the upper limb. And in one area of the flexor carpi radialis, we saw these small units. Overall, it was a confusing case. So we did the SSCP because of the asymmetry. We did not want to lose miss something which was acquired and at the level of the motor roots and the sensory roots, just in case it was like a CI-SMP or CI-MSP, but it was, the SSCP was completely normal from the lower limbs. So we then thought that are we dealing with some kind of odd myopathy with neurogenic changes? That was our final impression. Yes. Anything else, Satish?
No, I think before we tell about the further tests, I want to take one question and then we'll request Dr. Lalkaka to tell about what he thought about the case. So the question is, after examination, one should be able to say myogenic versus myopathic versus neurogenic. I like this question because there is a positivity of youth in this question. I think the answer is generally yes. In classic patterns, you are able to. But, the trouble with medicine is the more you know, the less you know. The more you see, more varieties you see, more atypical things you see. So if you really ask me today, can I for sure know after examination? I mean, my knowledge stock may be more, but I'll still keep everything. So I think at the end of it, I'm still going to keep both myogenic and neurogenic. And I think when you know a few things, you're very sure. As you know more things, you get slightly unsure because you know more. So I think that's the situation here. So yeah, so maybe we'll ask Dr. Lalkaka as to what he thought about this case. Is unusual. It's definitely unusual. So let's ask him, because he's seen, as you know, he's a very senior and seasoned neurologist, and he's seen this patient very recently also.
Yeah, thank you. First of all, you know, I've really been enthralled by Dr. Rakesh Singh and Guruji, Dr. Satish Khadilkar's discussion, and you know, I'd much rather be a spectator and in the audience. But let me just walk you through this patient. Really interesting. I saw this patient. Can you hear me properly?
Yes, yes, yes.
Yeah. You know, he's 18 years old. I saw him first early January 2020. He was in a rush because he's from out of Bombay, and he wanted to catch the train in the evening and go back to wherever, I think near Indore, Madhya Pradesh. And his main problem at that time was, as Dr. Riddhi very correctly mentioned, that he had difficulty in getting up from squatting position, and he couldn't run or walk very fast, and he had difficulty in climbing stairs. Incredibly, when I examined him, his proximal muscles were all normal. And what he had at that time was only bilateral ankle plantar flexion weakness. Bilateral ankle plantar flexors being around maybe 3 to 3+/5. Dorsiflexors were absolutely 5/5. And proximal muscles were also reasonably good on both sides. He had, as I said, a little bit of a pes cavus. There was, you know, his parents were first degree cousins. And so this is all that he came with. Interestingly, his difficulty in getting up and climbing stairs was actually not so much proximal muscles as the ankle plantar flexion weakness. And my first impression was that we are dealing with some sort of a long-standing, because it was 1 or 2 years, an inherited problem, maybe an inherited neuropathy. In view of the first EMG showing myopathic potentials, you know, I even considered distal myopathy. I wanted to investigate further. I wanted to get an MRI done. I wanted to get a CSF done, but the guy had his train to catch. So he went, and I thought that this is a slow progress and it's all right. You see me after 6 months. And he went away. That's all. 3 months later, I get phone call upon phone call. कि अरे साहब उनका तबीयत बहुत खराब हो गया है. I said क्या खराब हो गया है? थोड़ा 1-2% बढ़ा होगा और क्या? I said नहीं साहब अभी नहीं हो. He's not able to walk. He has fallen down 2-3 times. Initially I didn't believe him. I told him come to Bombay, but he said I can't come because of the lockdown. And ultimately I saw him on the video consult. I saw him on 2nd of July, which means about 6 months. 6 to 7 months, just 6 months from the time I first saw him. And I was shocked. He had a very significant deterioration. He had now, and his right side was affected much, much more than the left side. His right gluteal muscles, his hamstrings particularly, were about 3 to 3+. Both his ankles, now dorsiflexion and plantar flexion, were affected. And he was distinctly limping. Again, pure motor as far as I could make out. But there was a very significant deterioration, very fast deterioration, and it was very asymmetric. And then, of course, I told him, look, whatever happens, you have to go to a big center, either go to Indore or come here. He chose to come here. We got all the tests done. And so this is the whole situation. I thought this was some sort of an inherited, either a neuropathy or myopathy, but his subsequent progress really looked like an acquired problem. Now I think we can go on to the investigations and then, you know, try and combine the two.
Yeah. I just want to thank Dr. Mansukhani for taking time out and being here. She had some other commitments, so she'll be leaving. Kushnuma, thank you very much for joining.
As we know, whenever we are more confused, we investigate more. So after NCV report, we were not sure whether it is a pure neuropathy, it is a myopathy, or it is a combination. So what investigation Riddhi you will plan in this scenario?
Yes. So, sir, as we are thinking of neuropathy more than the myopathy and the CITP more likely, so we had considered for the MR neurography to see for the proximal nerve plexus involvement. So T1 weighted sagittal image was normal. T2 weighted sagittal image was
Jimmy, can
also.
we ask you what prompted you to do this study?
No, I think to be honest, I think there was a neurogenic element. He had an ankle plantar flexion. I was looking more at the L5, S1, root, disc and things like that. To be honest, I wasn't really thinking of, anything more than that. I just wanted to make sure there was no compressive pathology in the lumbosacral region.
Yeah, absolutely. I mean, as I'm looking at it now, I think the way you mentioned it, that the posterior compartment of the leg was weak originally. Then the posterior compartment of the thigh was weak. Then one side was so much weaker than the other. I think it's really strongly like neurogenic in that way. So I suppose one has to look at the lower spine and the conus cauda and that region. Yeah. Sorry, Riddhi, do go ahead.
Yes, sir. So this is a stir image showing the bilateral thickening of the nerve and the post contrast also. There was multifocal enhancement was there. So it was not continuous. So here also we can see this is, yes sir.
Can you show us the enhancement, please?
Yes sir. This red arrows.
The red
This red arrows showing the enhancement of the cauda equina. That is multifocal, not uniform.
There is quite a strong enhancement. Huh? Riddhi, are there any other scans to show?
Sorry, sir.
Sunila's report there.
Sorry, sir.
Is there Dr. Sunila Jaggi's report?
Yes, sir. I had not added in this one. So,
okay,
yes.
You read it out. Yeah. So you just show that, show the MR neurography again. I will explain. Yeah. I think for, I don't know how many of you are conversant with the images of MR neurography. But if you look at these segments, these are the S1 segments, L5 and S1. They are definitely much thicker than normal. And if you look at, I mean, this is what I was seeing, Jimmy, when we discussed this. This is the dorsal root ganglion. This is the preganglionic segment. And this is the postganglionic segment. So as you see, as you go lower down, there is a definite thickening of the postganglion. And actually, there are more images. As these go down, they become thicker. So, and the enhancement. So there is a definite thickening and enhancement of the L5 S1 segments where your clinical deficit was, one side more than the other. Yeah. So what is Sunila's report on that? Riddhi?
Yes.
There was marked thickening of bilateral roots, irregular contrast enhancement. That was the final impressions.
Yeah.
I think it was a combination of both. There was a thickening of the nerve root and there was contrast enhancement. Both of them were there.
Yes.
Yeah. I think Dr. Ilavarsi again points out another important thing which is important for the postgraduate students. If you do a CSF first and then do an MRI, contrast enhancement can be seen as a spurious thing. But in this particular patient, MRI came first. And the lumbar function came afterwards. Is that correct, Jimmy?
That's right. Absolutely right. the MRI was done elsewhere, and then he got admitted and then got the CSF.
And therefore, the decision for CSF because the MRI showed this.
That's right.
Okay. Fine. So, further thoughts, Riddhi? So the CSF now.
Riddhi?
CSF was showing high proteins.
Riddhi, have we probably lost Riddhi's touch? Yeah.
CSF was showing high proteins with normal cells. So it went towards demyelinating.
Yeah, Rakesh, CSF was interesting in the sense that the proteins were mildly raised. They were about 50 mg% with 1 or 2 cells. But what was interesting is that the CSF IgG and the CSF IgG index was significantly raised, more than almost 10 times the normal.
Yes. Yes.
So that would suggest that there is a intrathecal synthesis of the immunoglobulin.
Right.
So, any other tests to show protein electrophoresis? Yeah. Okay. So, Jimmy, you want to put your thoughts finally together?
No, so I mean, it was so confusing and so interesting. It looked more like a long-standing inherited problem. And I wonder whether there is still some, with his consanguinity and all, whether he may be having some baseline underlying inherited problem. And on top of that, he has, a superimposed inflammation of the nerve roots, probably a demyelinating neuropathy superimposed on a long-standing, inherited problem. That is, of course, Satish, what do you think?
Yeah, I mean, first of all, the asymmetry is there. Secondly, the pes cavus is there. The consanguinity is there. So I am thinking along the same lines as you are saying, that here is a process that's probably going on quietly for a long time and has gathered speed now for a few months, which you have documented actually in your examination. There's no doubt about the fact that last few months the patient has gone down remarkably. So it could be one of those most unusual situations where there is an inflammatory component to an inherited process, and both will produce the thickening of the plexus and the roots, as we know. But enhancement is more common with the acquired ones. Now, I got one other question. Where is this disease anatomically? It's only restricted to the roots, or it's also gone to the nerves? Riddhi, you have any comments on that?
Hello. Yes, sir. So, I think root and nerve both involvement is there, sir.
Why do you say nerve? Why nerve?
Sir, actually in between I got disconnected, so I could not hear properly that previous discussion.
Okay. I think the nerve is spared here because your distal sensories are normal, your distal motors are normal, all your parameters distally are normal. So, in fact, your MRI has shown changes which are of thickening and enhancement. Your clinical is somewhat matching with what the MRI is showing. The electrophysiology is telling you that the distal segment is normal. So you're probably looking here at a asymmetric, now rapidly progressive, isolated disease of the radicals, which is such an uncommon illness. But I think that's what it seems to be here. And to complicate matters, there could be something more in the background. So this could be acquired on top of inherited, isolated radiculopathy, which is thickening the roots. It's I know it's a crazy diagnosis to make, but that's the closest that I think.
But the answer came after treatment. Means some of the answers came.
Yeah. So
yes,
are there any?
We started immunomodulation.
Tell about the treatment that you gave.
Yeah.
Hello.
Yes.
No, so I mean, again, this was a a difficult thing, but I think there was enough evidence to suggest an acquired inflammation. He was going rapidly down. And so I started him on tablet prednisolone, 60 milligrams per day. And I had a video chat
So
3 weeks.
that was based on the IgG index and
that was based on the inflammation of the nerve roots. It was based on the IgG index, correct? And the very rapid decline and asymmetric course.
And enhancement on the MRI.
And enhancement on the MRI.
Parameters too, yeah.
Yes. So on that basis, to some extent, empirically, I started him on 60 milligrams of prednisolone. I think he started on 30th of July. I had this thing with him on the 20th or 21st of August, just now 10 days ago. I'm very happy to tell you that there has been not a little improvement, but a pretty significant improvement. The
Yes,
father
sir.
and the child were happy because, he couldn't run and he could now almost, he was falling down, he could walk, there was no limp, he could stand on his toes. The hamstring and gluteal muscles were still weak, but there was a significant improvement, not a little, but there was significant improvement in a span of 3 weeks. So that of course doesn't mean that there can't be anything underlying, but I think there probably is some acquired inflammatory change happening.
So probably you will bring him back and do studies again after a while. But you're planning to keep him on steroids? Are you planning to keep him on corticosteroids?
So I think hopefully if once the lockdown ends and it's easier to come, then one would definitely love to assess him again, to investigate him again. I plan to treat him, 60 milligrams, and now I'll probably gradually start, reducing the dose like we do for CIDP, maybe by 5 to 10 milligrams every 15 days. Keeping a watch on, side effects and sugar and BP and calcium and vitamin D.
Yeah, and I think the case is so unusual that how the patient does will largely tell you what you will be, what sort of protocol you will be following. So Sudhir, how are we doing for time? Is there time for some literature to be seen, or are we 10 minutes, 5-7 minutes?
Yes, sir. Please,
yeah.
Please.
So can I share my screen?
Yes.
You can go on for next 20 minutes, 15-20 minutes, no problem.
Great. So can you see my screen?
Yes, sir.
Yes.
Yeah. Okay. So very frankly, we have seen a very, very unusual case. The case is still new, and we have to still see how the patient progresses and what finally happens to him. We do not have a very good explanation for the myopathic changes on the EMG at this point in time. We know that mitochondriopathies can have demyelinating neuropathies and myopathies together. We also know that neuropathies give secondary myopathic changes. And we also know that what we're trying to say, acquired on top of inherited, is a very small, rare group. So only when we follow up this patient and do more tests, we will know. But the case is such that I thought I'll give you a little information on chronic immune radiculopathies. Radiculopathies, not radiculoneuropathies. Radiculoneuropathies, the classic example is the CIDP. So what are these diseases? They are very uncommon. They produce isolated involvement of the roots, and the nerves remain normal. Why that happens, we don't know. But see, you have got diseases like that you have got DADS, the condition of DADS, which is very, very distal. You've got CIDP, which is distal and proximal. And you've got the chronic immune radiculopathies, which are only proximal. So in such patients may have sensory ataxia or lower limb weakness, like our patient has got, with areflexia. And you do the distal conductions, the sensory parameters, the motor parameters, you will find them normal. You will do an MRI of the spine and that will be normal. And then you will not understand where is the localization. But if you have a good electrophysiology backup, then you will look at the F wave, H reflex, and SSEPs, and you may find abnormalities. And like you saw in this patient, the MRI will show a thickening of the roots, and often there is a albuminocytological dissociation. So that's the constellation in general. Yeah. So I think in view of the time, maybe I will very, very briefly show you the first case like this, which I saw about 10 or 12 years ago, where this patient came with tingling numbness in both feet for 5 years, then slipping of footwear without knowledge, then difficulty in getting up because of imbalance, and the imbalance worsened with eye closure, and calves had some rippling movements. Examination, he had a sensory ataxia, areflexia, and very mild weakness of the dorsiflexors and iliopsoas, and the Romberg was very strongly positive. So he had a sensory ataxia, areflexia, a little motor weakness. We didn't know where exactly the localization was. And this is the course that happened, like I told you. The distal conductions were normal. MRI of the spine was normal. So we didn't know where it was. But the SSEPs from lower limbs were abnormal. Those from the upper limbs were normal. And this was a time when we had just started doing the MR neurography. And these are our early pictures of the 1.5 Tesla, where you can see the S1 roots are so much thick. And here you will appreciate. Look at all the thick roots. You don't see them as thick as that in the standard MRI. And here you see how thick they are. See, MR neurography was new at that time. And because you could take pictures from all angles, somebody has taken them from all angles, and you can see the S1 roots are very, very thick. CSF protein was high, cells were normal, OCBs were there. And this was our first patient whom we saw selective proximal demyelinating neuropathy affecting lower limbs causing sensory ataxia. So what is the information today on these rare conditions? People know that they can be pure sensory, which are called CISP. They can be sensory motor, CISMP, and CIMP, which are chronic immune motor. So the first of these three to be described was by Sinrich and his colleagues and co-workers, where he had 15 patients. He termed it chronic immune sensory polyradiculopathy, a possible treatable sensory ataxia. And very interestingly, he had 15 patients, not a small number, who presented with sensory ataxia and areflexia without weakness, normal distal conduction studies, prolonged SSCPs, albuminocytological dissociation. He had 5 MRIs, which showed thickening of the rootlets, and he had 3 biopsies of the roots, which showed inflammation. I think biopsy is an important thing because conditions like lymphomas, other infiltrations, and things like that you can pick up only on a biopsy. All his patients responded to corticosteroids and immunosuppressants. After his first paper, then you got papers talking about cranial neuropathies in patients who are CISP. Then papers saying that how SSCP is useful, papers saying that IVIG are useful. But there's a single paper by Rajaballi and Wong, whose patient deteriorated after steroids and then improved with IVIG. So there are at least 7 or 8 publications, case series and case reports, which all say that they respond to immunotherapy, particularly corticosteroid, which is a very important information to the therapeutician amongst us, except Rajaballi and Wong's case, which did badly on steroids and did well again on IVIG. So that was the CISP. After the CISP, we had 2 patients, one in Grant Medical College and one in Bombay Hospital, where these patients were like CISP, but in addition to CISP, they were very weak. And they also had chronic denervation and renervation pattern on their electrophysiology. So we described these two patients and said, look, this is expanding the spectrum of the CISP, call it CISMP. These two patients also did very well on immunotherapy, and they had the same thing: sensory ataxia, areflexia, weakness, albuminocytological dissociation. The year after that, I think there is the only other report, a series report, is by the group of Bashar Khatirji. They retrospectively looked at, and there is a very interesting anecdote to this. In one of the meetings, I showed these two patients of CISMP. I meaning, I think Dr. Patel or somebody showed the case. And he came back to tell me, sir, one particular foreigner was very, very interested in what I said, and he was asking me questions. So it turned out that he was Bashir Khatirji. And he went back and asked one of his fellows to look at these. And they did a retrospective analysis of 3 institutions, and they had 9 cases with exactly the same findings. Weakness, ataxia, areflexia, same thing, thickened rootlets responding to immunotherapy. So the second condition is CISMP. And there are very few cases of CIMP on record, which is purely motor. Now there are these 3 forms, and in the last 10 or 12 years, we were collecting cases. So we kept them together and analyzed them. And only this month, this has been published in Muscle and Nerve, where we thought that all our cases who look like CISP clinically have the motor component electrophysiologically. Those who look like CIMP clinically, their electrophysiology shows sensory ataxia. So we think that they're all the same. 3 forms of one disease. So we call chronic immune polyradiculopathies 3 clinical variants of one disease. And we had 8 patients in whom we showed that all of them had sensory and motor roots affected to different proportions. So we don't know why some are more sensory clinically, why some are more motor clinically, but electrophysiologically, MRI wise, they look the same. So we propose that the main form is CISMP, and there are others, they're not actually CISP, they're CI into small print M and CI into small print S. So look at these 3 different. This is CISMP, this is CISMP full, and this is the motor one. They all look the same. And this is normal for those who are not too used to seeing these. So I think that's all that information is available at the moment on chronic isolated immune radiculopathies, that they can be sensory, they can be motor, they can be mixed. Why they are proximal, we don't know. Whether they will stay proximal or given time they will become CIDPs. Though we don't know, we don't think so, because our patients have had histories of 5 years, 4 years, 8 years, like that. So that's about this topic, and I'll just tell you a little bit, show you about MR neurography. I think MR neurography is a fantastic technique, and you see how beautiful the images come out. This is neurofibromatosis 1. This is HMSN PMP22 deletion, and in this particular family, we have 3 generations with clinical anticipation and radiological anticipation as well. This is the grandson, and his nerves are far thicker than the mothers and the grandmothers. This is published somewhere. And this is a CIDP where you see the enhancement. So I think enlargement of the roots, nerves, plexi is a very important sign which sort of narrows down your differential diagnosis. And in the journal Practical Neurology, we have done an approach a couple of years ago. And recently we looked at optimization of investigations of enlarged nerves in a series of 133, and our radiologist has become quite good at normative data and other things based on these 133 patients. So just to finish off, you saw isolated proximal radiculopathy, similarly isolated hypertrophic plexopathies are known. I'm showing you two examples. This is almost like tomacula. So there are forms that affect both the lower limbs. There are forms that affect only one upper limb. And there are also forms that I'm not showing today, which affect a single nerve. So the spectrum of these conditions is huge, and only a little bit we know. But I think it's good to be aware that these rare conditions can exist. Now, our patient very likely has an acquired form of immune radiculopathy, but it is on top of something more. And maybe next year when we do this program, we'll tell you what more it was. So Sudhir and Lakshmi, we would like to thank you very much for giving us this opportunity to present this case. I know we've chosen a slightly unusual case. I know common things are common, but I think DM neurology students attending this.
No. This is sir, you have given us a real feast for the night. It's an intellectual feast for the night, and I hope everybody who has attended would have learned so many things. Especially the MR neurography is fantastic, sir. And I'll just have a look through what are the questions is there.
Yes.
Fantastic talk.
Dr. Bharucha or Dr.
Most of them, sir, most of them are high prices for you. Somebody has said that you are as fresh as a rose, even in the.
Because I'm doing nothing, Lakshmi.
And sir, this pandemic is a blessing in disguise. I'm able to listen to great teachers like Professor Satish Khadilkar. Thank you all. Most of them are. Excellent. Sir, the asymmetry, there's one question, sir. Yeah. Asymmetry is only relevant when there is a difference of more than 2 MRC grades.
Yeah.
Is it true, or is the patient's power chart? I don't think there is much asymmetry. Please comment.
Yeah. I think what is said is very correct. That if you have 2 MRC grades or more, then you know that there is a definite asymmetry. But even lesser degrees of asymmetry will be relevant in a given case.
You cannot ignore.
So it's like Sherlock Holmes. Use everything that you have.
And sir, Professor Sudhisha, sir, would you like to?
It was a mesmerizing talk, and of course the clinical discussion was also exemplary. And ice on the cake is the fact that we have 2 great doyens sitting with us, and Dr. Satish Khadilkar, one of the great neurologists of our time, is with us, who has given a wonderful insight of such a new topic with wonderful slides. And of course, the radiology and our orientation to MR neurography. I think today's second episode has really, in a way, shown how we are escalating every time, and maybe next time we'll have another great webinar. I am here to thank Dr. Lakshmi particularly, because I must say that more than me, he has slogged for all this work. So thank you, Dr. Lakshmi.
Thank you.
I must thank Dr. Satish, who is not only my close friend and colleague, we studied together, but the mastery of the subject and the way he teaches, and the modesty and kindness that he has shown to each one of us. I think a friend needs a salute. And so same is Jimmy, my very noble, lovely, kind friend. And thanks to Rakesh and of course the presenter student. Thank you very much. And once again, I thank all the delegates. I thank INTAS team. And maybe we may announce, Lakshmi, would you be able to announce the next date of webinar?
Before that, there is one important question. Somebody asked, sir, Professor Khadilkar, sir, somebody has asked, do you consider Lyme's disease in this scenario?
Yeah. I mean, whenever you're talking of the conus cauda region and the lower cord, infections will enter the differential diagnosis. Inflammations will enter the differential diagnosis. Infiltrations will enter the differential diagnosis. So all these thoughts are there, but most of the infections and infiltration that I have seen are very painful. well, this patient is pure motor. This patient is going, the history is stretching over a rather long time. These points will make these diagnoses less likely, but having said that, every effort should be made to exclude them because they are treated differently and they are treatable. It's a very good point, actually. Even a lymphoma, neurolymphoma, very tricky.
Thank you so much, sir. Before we wind up, I would like to announce that the next September 26th, last Friday, from West, we are moving to South, CMC Vellore, under the leadership of Professor Vivek Matthew. They will do the next Friday meeting, September 22nd on 8 p.m. Hoping to join with all of you with new clinical material. Thank you so much for all of you. And it was really excellent, sir. As usual, you're stolen the show. Thank you. And you have set now you have set the bar very high. You have to, everyone has to prove a rung above this presentation. It's very, very difficult. Thank you so much for your kindness.
Thank you. Thank you
very much.
Thank you, sir. And
thank you all very much. Yeah, Satish, you really set the bar high. Yeah?
Yes, sir.
With this case. Yeah.
Sir, Professor Beam Singhal, sir, you would like to say anything, sir?
Probably, I don't see him here.
Okay. Okay. Thank you.
Maybe Dr. Ravi, would you like to say something, sir? Professor Bharucha?
Dr. Bharucha, you want to close?
No, I think, I just have closed by saying there are a lot of methodical work that all of you may not be aware. Even this MR neurography is something that Satish has developed, working closely with the radiologists. It's not something I was aware of at all. And then subsequently it just goes on teasing, gets little bits of information, puts them together. And I think for all of us, it's a lesson that, you can just start collecting cases over a number of years and then trying to spot a pattern and then trying to find a new technology to delineate that condition. I think that's very good. Yeah. I've certainly learned a lot. Thank you.
Thank you, sir.
Thank you, sir. Thank you. And so, sir, we have come to an end of episode 2, Secrets of Neurology. I, Arun Chadha, Senior General Manager in Taj Pharmaceutical, would like to thank you from the bottom of my heart for the overwhelming response from all the delegates. Today's session was truly an enlightening session for all the delegates. Due to the presence of honorable dignitaries, Dr. B.S. Singhal, sir, Dr. Nadir Bharucha, sir, we are really grateful to you, sir, for gracing this session with your presence. And I would like to thank Dr. Riti Patel, Dr. Rakesh Singh for wonderful discussion, the case, and Dr. Jimilal Kaka for his expert opinion. The review on the case by Dr. Satish Khadelkar, sir, was like a cherry on the cake, which summarized and explained all the angles of the cases. I would like to thank to Dr. Mansukhani ma'am for throwing light on electrophysiological report. Last but not the least, I would like to thank Dr. Sudhir Shah sir and Dr. Lakshmi Narasimhan sir for their interactive discussion and bring together to us the various cases on the neurology in the form of this webinar, Secret of Neurology, which will be broadcast on every last Friday of every month. Once again, we thank you for your presence. See you for the episode 3 with the interesting guests. Thank you, sir. Till then, stay safe and stay care.
Since you call this secret,
yes, please.
Call this secret of neurology. I think the secret is only one: an inquiring mind and a desire to help. Everything else is available. No, Professor Google has everything. Inquiring mind and a desire to help. That's the secret of neurology, medicine actually. Yeah. Great. Thank you. Thank you.
Thank you, sir.
Thank you, sir.
Thank you very
so
much.
much.
Thank you all.
Thank you. Thank you very much, sir. Good night.
Thank you, sir.
Good night, sir. Good night, sir.
Good night, sir.
Good night, sir. Good night, Dr. Rakesh.
Thank you.